Okay, so let's wrap up the heart PowerPoint and get to the second half. We've got almost 80 slides here to get through. We're going to be talking mostly about remember the first part of this, the first PowerPoint was the name of the part. So it was anatomy of the heart. We're now going to do the physiology. We're going to talk about the conduction of electrical signals through the heart and the contraction of the heart and how things are coordinated to make it into a decent pump. Okay, so um, the heart depolarizes and contracts on its own, even if there's no input from the nervous system. The heart has these built-in pacemakers. These are sections of the right atria that are auto-excitatory. They will get, and I'll go ahead and tell you why. This is because they have leaky sodium channels. Their sodium channels allow small amounts of sodium. Remember, normally like if you think of a nerve, we pump all the sodium to the outside and the potassium to the inside of the cell, and then they stay there. Well, we're still going to pump sodium to the outside, still going to pump potassium to the inside, but the channels don't fully close. Some of them leak, and that allows sodium to leak into the cell, and it gets a little more positive, a little more positive, a little more positive as the positive sodiums are leaking in. Anyway, though that's what serves as the pacemaker, and you have two spots that way. One is the sinoatrial node. That's your primary um, pacemaker. If a heart attack were to destroy the cells in it, you do have a backup one, an AV node. Now, the heart rate is going to be different. It's not going to work as well, but the AV node is there as a backup system to keep the heart pumping at least. Now, this rhythm that the heart would have, this natural rhythm, you can change it with the autonomic nervous system, especially with signals from the vagus nerve. We are slowing the heart rate down normally from what the SA node would tell it to be when we're at rest. But when we are not at rest, we might speed it up. It might have to work harder. Like if we are exercising, we need more oxygen, we need more blood. We're going to send signals to the heart telling them to speed up. Okay, we've talked before about the gap junctions that are found in the intercalated discs that allow chemicals building up in one heart cell to move to the next one, and how that means that all of the heart cells are electrically connected. Um, so there are two things that affect the conduction of the heart, or that coordinate the function of the heart. One of those is those gap junctions that allow them to communicate with other. The other are the things I talked about before, the SA node, the AV node. You can see them in the picture right here. The SA node is high in the atria near the superior vena cava. The AV node, you probably guessed, since it's the atrioventricular node, is low down near the junction of the atria and the ventricles. Both of those have these non-contractile cells. Their job is to distribute impulses and coordinate depolarization through the heart. Everything you see in yellow actually has the job of electrical conduction. We're going to go through all of these, but very quickly, we're talking about the SA node, the AV node, the AV bundle that goes through from the atria to the ventricles, the bundle branches, the Purkinje fibers, all of that stuff. All right, so action potential is started by pacemaker cells. You already know those are in the AV nodes, the SA nodes. They don't have a stable resting potential. If you remember, a nerve cell hangs out when it's at rest, it's at about -70 millivolts, and it just stays there. The heart cells that do electrical activity, they don't ever go quite that low. They're a little bit higher. And even when they're at their lowest, they don't stay there. So say we're about to send a signal. We're down here almost at negative 60 millivolts. It's going up, 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 up in charge. Why is it doing that? Because it has a slow leak from the sodium channels. See, those sodium channels are letting sodium leak in, and so the cell is getting less negative, less negative, less negative over time. All right. So when we are sitting, when we're looking at this going on, the potassium channels are closed, but the slow sodium channels are open, and they're allowing sodium to leak in. When that happens, you're going to get more and more and more positive until you finally hit the threshold. The threshold is around in a cardiac cell is around negative 40. Negative 40 is still negative, but it's a heck of a lot closer to zero than negative 60. Okay, so we are moving towards zero, and that's why we say we are depolarizing. Okay, when those channels open, you're going to have a huge rush. Well, what happens at the threshold when you get this negative 40? You open up fast channels, but in nerves, remember, we were opening up sodium channels. Now we're opening up calcium channels. We're talking about a muscle. So this is more like the the skeletal muscle, where you're going to open calcium channels and calcium is going to rush in. And a whole bunch of calcium coming in will increase the will make the charges increasingly positive, much closer to zero, and that's the rising phase of the action potential. When it gets high enough, long enough, you're going to open up slower potassium channels. They take longer to open, but when that happens and they open, all the potassium rushes out. So we're now losing positive, losing positive, losing positive, losing positive. Fancy way of saying becoming more and more and more negative until we get down to there, down to the bottom, down to around negative 60. And at that point, we're going to start the whole process over. Pump things back where they should be, and then the sodium is leaking in, leaking in, leaking in. That rise right there from the bottom up to the threshold, the rise that is caused by sodium ions leaking into the cardiac muscle cell, we call the pacemaker potential, because this is happening in the cells of the pacemaker, the SA node, the AV node. All right. So here we have going through step by step what's happening. You can see that during the pacemaker potential, the potassiums are closed, the sodiums are leaking, so we get more and more positive. If you hit the threshold and open the calcium, calcium rushes in. That causes a depolarization wave. And that's going to go on until we open the potassium. When we do, there will be an efflux of potassium. That's a stupid word. I wish the book didn't use it. But to remember what it means, the E in exit, the E in efflux, same thing. This is potassium exiting the cell, which makes it more and more and more negative. Is losing all those positive sodium, so it becomes more negative. Then we'll start it all again. All right, so let's go through the order of sending the electrical signal through the heart. You start at the SA node, then the signal goes to the AV node, and then goes to the atrioventricular bundle, which goes through the junction of the atria and the ventricles. Don't worry, we're about to go over this whole thing, but then it goes through the right and left bundle branches. Those are traveling through the interventricular septa down to the apex, and then it curves around. Now, All of this electrical activity, these electrical signals are passing through special cardiac cells. They are a lot like nerves, and they are big, big diameter. So if you think of a power cord for a cell phone. It's an electric cord. Now think of jumper cables. The jumper cables for your car, those are much bigger diameter copper wires. Why? The bigger wire has a lot less resistance. You can pump a lot of current through it fast. The reason these cells are fast, the reason they send electrical signal through the heart so quickly, they're big diameter. Big diameter lets the signal go real quick. Anyway, but let's go through these. We have the two pacemakers. We have the SA node. That's a primary pacemaker. It's in the upper right atria, and it depolarizes faster than the rest of the muscle cells in the cardium, in the heart. And if it's left to its own devices, if you're not sending it signals to slow it down, it would try to make the heart beat about 100 times a minute. That's too fast. So we actually are sending signals from the body, mostly the vagus nerve, slowing it down to 75 times a minute on average. And the that impulse, the action potential that starts in that cell, it goes across the atria and to the AV node. Well, what's with this across the atria and AV node? Why isn't it going? You can see across the atria is this distance, big distance, but then we have a shorter distance right there. Why hasn't it, if it can travel that far, why isn't it traveling that far? Well, here's the thing. I told you before that all the cardiac cells are electrically connected because those gap junctions in the intercalated discs. True, sort of. In reality, the signals don't pass from the atria to the ventricles very well. They'll spread through the atria really well, they'll spread through the ventricle really well, but there's only one spot that we pass a lot of signal from the atria to the ventricles, and it's through the AV bundle here. Imagine the septa, the atrioventricular septa. Imagine that they are insulating and they stop the signals, except that there's a hole through that insulating layer that these big, wide, electrically conductive cells are located at, and that would be the AV bundle. Some people used to call it the bundle of His, HIS. I don't know why. Anyway, but that signal will spread across the atria, and it will go from the SA to the AV node. So from here to here. Good. And I might as well get this out of the way right now. Understand that the electrical signal is the signal that tells you you should contract. It is not the contraction. We have that another slide much later in here that is wonderful at showing that, but basically you can't respond to a signal unless you have the signal. You can't do the contraction unless you have the signal saying time to contract. So what we are studying right now is the spread, the propagation of the electrical signal. We'll go over the contraction later, further down in this PowerPoint. All right, so we're just talking about the electrical signal spreading. It goes across the atria, goes to the AV node. It's slowed down there, it's delayed. The delay is on purpose, it's built in, it's natural. Why? So before we have our ventricles starting to contract and push blood out, we have time for the atria to contract and push and top off the ventricles. So we need to slow it down a little to give them time, to give the atria time to finish their job. How do you do that? Narrower cells. At the spot we need to slow it down, we have narrower cells. Think instead of the jumper cables, we have the very narrow phone charging cord. Okay, easy enough. Now, the AV node, it is a backup pacemaker. If you had a heart attack that destroyed all the cells in the SA node, your heart would still beat because the AV node would still have you pumping at about 50 times a minute. That's not much. What that means is you might be alive, but you're not going to run from a bear. You may not even be able to stay conscious, but the heart is pumping. It's trying to keep the body and brain alive. Okay. Now the AV bundle, that's the signal that goes from the atria to the ventricle. It travels through these cells, and it's found going through the superior part of the interventricular septa. It is the only electrical connection between the atria and the ventricles. We already said that. The atria and the ventricles are not connected through gap junctions, but all the atrial cells are, all the ventricular cells are, and there is a connection through the AV bundle, but nowhere else. Like I said, think of the AV septa as being an insulating layer. All right. Once you get further down the ventricle, further down the interventricular septa, you're going to divide into left and right bundle branches. Those two bundle branches will carry the signal towards the apex of the heart. Send the signal down. Once you get there to the apex, signal continues and goes up the wall, through the wall, and the book is using the subendocardial conducting network. Never heard that. Always just call it Purkinje fibers. On your test, it's going to be Purkinje fibers. So they will complete the pathway through the septa into the apex, through the walls of the ventricle. You can see it's a lot more branching, a lot more elaborate on the left. There's a lot more muscle on the left that you have to innervate. Okay. A lot more cells on the left side that need to be told that they need to do something. So the atrioventricular bundle and the subendocardial, I should just rewrite that, and the Purkinje fiber conducting network, if they were not getting a signal from the atria, they would still make the ventricle contract. It wouldn't be as efficient, but they would do it about 30 times a minute. Again, we're trying to just keep some blood flow to have a backup system. Ventricular contraction will follow from the apex towards the atria. What they're saying is in the ventricle, you're going to squeeze from the bottom up. You'll start the squeeze at the apex, then you'll go upward. Here. Think of a tube of toothpaste. You don't grab the tube of toothpaste in the middle. If you want to get all of the toothpaste out of the tube, you need to start the squeeze of the tube at the end of the toothpaste, end of the package. Then you force the blood upward, force the toothpaste upward. Well, same thing in the heart. If we let the signal cross the septa and start here and then go down to the apex, we would start squeezing in the upper ventricles before we squeeze the lower, and we would trap blood in the bottom. It's inefficient. If you want this to be efficient, you have to start the squeeze at the apex and move upward. So you squeeze the blood from the bottom to the top, where our semilunar valves are. Our pulmonary and aortic semilunar valves that open to allow the blood into our major vessels. So anyway, yeah, you got that. All right, so let's talk about arrhythmias, homeostatic imbalance stuff. If you have irregular heart rhythms, uncoordinated contractions of the atrium and ventricles, highly inefficient, not moving enough blood. If you have fibrillation, meaning one of the chambers is just quivering, then it's useless for pumping blood, and you may not have any circulation going on. That could kill you. You shut your brain down because you're not getting the oxygen. How do you solve this? You could use a defibrillator that'll basically reboot the heart. It's not restart the heart. The heart's running and quivering and doing nothing. It's depolarize everything and then see if we can start up the pacemaker again to get a nice clean signal. If you have a damaged AV node, the you might have to use a different pacemaker. Sorry, a damaged SA node. You might have to use your AV node, and it's going to have a different rhythm. It'll be slower. If you have extra systole, extra meaning above or outside of, so we haven't talked about diastole and systole yet. Easy to remember. Those are your high and low blood pressure. How do you remember which is which? High, think Superman flying high above. So your systole is the high pressure. Diastole is the low. Think down low, like the dirt. Okay. So if you hear those words, systole and diastole, systole, that's what we're talking about, is the two pressures, the high and the low. So if we have a premature contraction, this happens because something is firing before the SA node can, and that'll delay the impulse. The heart has to take longer to fill, and the next contraction will be a thud because you're pushing out a big amount of blood. Too much nicotine, too much caffeine can cause this. All right, to reach the ventricles, you have to send the signal through the AV node. And so you start in the SA node, then you have to send the signal through the AV node. What if your AV node is dead? What if it's defective? If it's complete, if few things are getting through, we'd say there's a partial block. If nothing gets through, like it's dead, we'd say there's a total block, a complete block. And then the ventricles are going to beat at their own rate, but it's going to be too low to be useful to you. The reason why is that we do have a third ultra slow right here in the AV bundle pacemaking, but 30 beats is not going to keep you running. So treatment, what do you do if you have a block? You could you could put an artificial pacemaker in here, which will recouple the atria and the ventricles. So now the heartbeat is modified by the autonomic nervous system. We already said this. You know that the heart rate, if it was left up to the SA node, would be faster, like 100 beats a minute. But we have a cardio inhibitory center and a cardio acceleratory center. Those send signals to the heart to either slow it down with the inhibitory or speed it up with the acceleratory. The vagus nerve is part of the cardio inhibitory, the parasympathetic, and that will slow the heart rate down to whatever our normal resting rate is. That's inhibiting the SA nodes, inhibiting the AV nodes, just keeping everything slow. Now, if we need to speed things up, we use the other part of the nervous system. We're using the sympathetic trunk. remember your sympathetic nervous system be your fight or flight. That's when you're, oh wow, we need to speed this up. We need more blood to the brain. We need more blood to the muscles. So you tell both the SA node and the AV node to get to it and do their job faster. Now, most of the heart is contractile fibers that can contract. They're the ones that pump, and the skeletal muscle contraction is a little different from a cardiac muscle contraction. Cardiac muscle contraction has a plateau that's a lot longer, a refractory period that's a lot longer. What that means is once a fiber has fired, it has to wait longer than a skeletal muscle would to fire again. That's good. That's the rest when we let the heart fill. Anyway, but we have a depolarization and a repolarization. Those are the parts of the action potential. Notice that in depolarization, bam, almost no time we've done the change in the membrane potential. Then we slowly go back to where we were for the next one. All right, so what's actually happening? If we have depolarization, we're opening fast voltage gated sodium channels. In other words, we're acting like a nerve. Remember I told you we had those slow sodium channels that leak? All true. But that was in the self-excitatory cells. We're now talking about the contractile cells, see? They don't have the leaky channels, they only have the fast channels. So the fast channels, you have them open and sodium rushes into the cell and it very rapidly becomes very positive. And that also will open slower calcium channels. That's important because just like a normal muscle cell, skeletal muscle, we need the calcium in order to be able to contract. We have to bind to the troponin, tropomyosin business, pull that out of the way so the thick filaments with their heads can pull on the thin filaments, all that stuff. So we need the sodium. So we need the potassium. And after those potassium channels, why did I say potassium? We need the calcium. Duh. So sodium channels close. Remember, they open for the rising phase of the action potential. Well, the calcium ones open too, but they take longer to close. So sodium opens, sodium closes, calcium closes. All right. That's that plateau, that pause there, that's the plateau. After about 200 milliseconds, those slow calcium channels close and the voltage-gated potassium channels open. Then potassium rushes out and exits the cell. And when it does, you're losing the positive potassiums, so you become less and less and less positive, more and more and more negative. That is the drop here. Okay, with sound effects, I promise. All right. During this time, calcium will be pumped into the sarcoplasmic reticulum. Remember, that's a modified smooth endoplasmic reticulum. And so we're starting to get back to where we need to be. Obviously, to get completely back where we need to be, we'll then have to pump the sodiums out and the potassiums in. But, an action potential in skeletal muscle will last 1 or 2 milliseconds. In cardiac, it could last 200 milliseconds. The contraction of a skeletal muscle will be 15 to 100 milliseconds. In the heart, it'll be over 200 milliseconds. The longer contraction gives you more efficient ejaculation of blood, ejection of blood. Sorry about that. It's still emission, it's still giving off, but that was totally the wrong thing to say. Anyway, longer contraction gives you a longer way of ejecting blood from the heart, moving it. The longer refractory period gives the heart time to fill and get ready to contract again. It prevents you from having, remember in skeletal muscle, we could have signals come so fast and we're responding to them so fast that you never get to relax. You just get stronger, stronger, stronger. Well, if we did that, the heart would never get to refill. So the longer refractory period lets the heart fully relax, let it fully get filled with blood, completely filled with blood. All right, so phase 1 is sodium, phase 2 is calcium, phase 3 is closing the calcium and having the potassium rush out. Now let's talk about electrocardiograms or electrocardiographs. You might say, what's with this ECG, EKG? Well,
right now in Winter Haven, it's 91 degrees
hold on.
Fahrenheit with partly sunny skies. Today's forecast has lots of clouds.
Alexa, stop. All right. All I was saying is that, by the way, I don't need Alexa giving us the weather during this. Sorry about that. An electrocardiogram. The reason we used to use EKG is a bunch of Germans invented this, and they spell cardio with a K. We do it with a C. That's why we now say ECG. That's that tracing that you see here, this famous heartbeat tracing. That's what you're looking at. And you put electrodes all over the body to see this. Yeah, sometimes in class you use a 3-lead. In a hospital, you're probably going to use a 12-lead. But it should give you this tracing. And here we have P, Q, R, S, and then this big T. So P wave, Q, R, S, and then T. And we'll go over all of this, don't worry. So the P wave is when the SA node and the AV node are depolarizing. The atria is depolarizing, so top of the heart depolarizing. The QRS is when they are repolarizing, but the ventricle is depolarizing. So what's this little gap right here, the PR interval? Sorry, right there. Sorry, if you wondered why I was pondering, I'm like, why are they not calling it the PQ interval? But anyway, this line right here, that is the delay that we were talking about that has to happen at the to let the atria do its thing. Anyway, QRS, we have ventricular depolarization, atrial repolarization. The T wave is the ventricle repolarizing, getting ready for the next beat. Now, the PR interval right here, that's when the atria is going to beginning of atrial excitation to beginning of ventricular excitation. Yeah, that's a fair way to say it. This is entirely the electrical. That's also about the same time what I started to say. In fact, I'm going to jump ahead so you can see it. We'll come back to that. Here you go. So that's also when the atria is actually doing its contraction, pushing blood into the ventricle. So you get the signal, and then a little later, you respond by contracting. Anyway, so I've said that, but we'll get to that. We'll get to that. Let's do it the way the book is. They're talking entirely about the electrical activity. Then we'll do the physical activity. So the S to T segment, this is when the ventricle is depolarized, entirely depolarized. And Q to T right there, that's the time from depolarization to repolarization. So T is the repolarization wave. Anyway. Oh, which it already said there. Yeah, you can see it. Okay, so let's go through these step by step. And to avoid confusion, I'll let you know this orangey yellow color, that's showing depolarization. The red is showing repolarization. And what they're doing is showing you what's happening here, and they've highlighted the part. So during the P, we have the electrical signal, the depolarization signal spreading through the atria. Okay. During this segment right here, between the P and the S, we have it spread fully. The entire atria on both sides is getting the signal that it needs to contract. Then QRS, we have two things happening separately. We have the repolarization of the atria. They've already contracted, and now they are pumping all the ions back where they were at rest. But you can't really see that very well because the much bigger ventricles with their much larger amount of muscle, they are now depolarizing, which is this yellowish orange signal still. And both of those things, the ventricles depolarizing and the atria repolarizing, those two opposite things in opposite ends of the heart, they're both hiding inside of this wave. They're both happening during that wave of electrical activity. The next electrical thing would be spreading the signal all the way up the sides. Now, this is important. We need to get the signal up to the papillary muscles in the wall before we start the contraction, because we need to stabilize those valves, the AV valves. Okay. And in the T wave, we are now depolarizing and pumping ions back where they belong. So we'll depolarizing, and then we're going to pump ions back where they belong. And then we have heart at rest. That is the period from the T to the P. Sorry, from the end of the T wave to the beginning of the P wave. That's heart at rest, ventricle repolarizing, and atria just chilling. All right, so let's talk about what can cause problems with this. And we're going to have some examples of, yeah, really messed up heart rates. So let's go through. Why do an EKG and an ECG? Because you can often tell what's wrong with the heart. If the R wave is too big, your ventricles may be too big. If the ST segment is slanted or depressed, you may have cardiac ischemia. Fancy way of saying that you may have occlusion of cardiac vessels. You're not getting enough blood to enough oxygen to the ventricles. If your QT interval takes too long, you're having trouble repolarizing, and that puts you at risk for arrhythmia. All right. So here we have normal. And by the way, I have much more in depth. If you look through the links that are links for this chapter, we have much more in-depth discussions of how to read EKGs. Anyway, but this is normal. The SA node is gone. It's dead. And that means you don't have a P wave. And that means you're not getting electrical signal going through the atria. The AV node is still trying to make the heart beat, but it beats a heck of a lot slower than it should. Okay, here we don't have much or any of a T. So the AV node failing to conduct some of the SA impulses. What that means is you've got more P waves than you do QRSs. You can see here's a P wave with no ventricle action. Here is a P wave with no ventricle action. Okay, so here we're seeing two P waves for every QRS wave. That means the atria tries and it tries again, and then finally the ventricle gets the signal and goes through. That's one of those blocks. That's a partial block where we're not sending the signal. Here, obviously the heart's going nuts. This is a quivering, a fibrillating ventricle. It's a horrible pump. It can't send blood because it's basically having a muscle spasm. So, all right. So, systole is when the heart's contracting. Diastole is when the heart is relaxing. The cardiac cycle is going through one complete heartbeat, the blood flow through a complete heartbeat. That means the stuff in the blood song. Atrial systole and diastole are followed by ventricular systole and diastole. It's just a fancy way of saying the heart's atria contract and then relax, followed by the ventricles contracting and then relaxing. These mechanical events, we already said it, follow the electrical events. They happen after the electrical events. The three phases of the cardiac cycle on the left side, starting with total relaxation. You're going to have the ventricle fill. This is in mid to late diastole. 80% of the blood, there's the figure that I didn't have earlier when I said it's more than half. Yeah, it's 80% of the blood flows, like it enters the atria and then it just runs through the atrioventricular valves and down into the ventricles. Okay, 80% of it goes through the AV valves into the atria. Then the atria depolarize and then they contract and then they top off the ventricles. They push the remaining 20% of the blood into the ventricle, finish filling it. Then we have what we call the end diastolic volume. That's the amount of blood in each ventricle at the end of diastole. Okay. That's a typo. Into each ventricle at the end of atrial diastole. Hold on, I'm going to fix that. Yeah, I know screen sharing stopped. Let's go over here. Okay. Wait. Okay, there we go. Much better. So the depolarization will then spread through the AV bundle to the ventricles. When the atria finish contracting, remember, the electrical signal comes before the contraction or relaxation. So we end the diastole, and then what we we end the diastole. So atria finish contracting, return the diastole while the ventricles begin systole, while the ventricles start their contraction. All right, so let's talk about do you remember in AP1 when we were talking about skeletal muscles, we talked about isometric and isometric contractions were ones where iso means same and metric is a measurement or a length. So an isometric contraction is one where you increase the tension in the muscle, but you don't change the length of the muscle, the skeletal muscle. Well, in the heart, we can have something similar. Isovolumetric means, it's right in the name, same volume measured. We are not changing the volume. What they're saying is that there's a moment where the heart is squeezing, but the blood is not coming out because we haven't opened the semilunar valves yet. During that time, the pressure is increasing, but the volume is not changing until we open the semilunar valves. So atria relax, ventricles contract. As the pressure in ventricles rises, it tries to push blood back up into the ventricles, but the AV valves snap shut and keep the blood below them. This is only for a split second when the ventricles are completely closed, all the valves closed. But when the pressure gets higher than in the arteries, those semilunar valves are going to open, and then the blood will flow from the right into the pulmonary trunk and pulmonary arteries, and on the left into the aorta and all the major arteries. So isovolumetric relaxation, we have early diastole followed by ventricular repolarization. The end systolic volume is the blood remaining each ventricle after systole. I already told you we're going to start the contraction at the apex so we can push the blood up and out so we can reduce the amount of end systolic volume. Ventricle pressure drops. It causes blood to try to flow back from the aorta, from the pulmonary trunk into the semilunar valves, into the heart. That shouldn't be able to happen. The semilunar valve should completely close and trap the blood up in the major blood vessels. And ventricles completely closed chambers, we call that isovolumetric relaxation. We're not refilling yet, we're just chilling out and relaxing. When the aortic valve closes, that will raise the aortic pressure. Backflow will the blood will try to backflow and it'll bounce off of the valve. This is the dichrotic notch. When you're tracking mean arterial pressure, you're going to see a change right there. Anyway, I should say arterial pressure, not mean arterial pressure. The atria will keep filling during ventricular systole, meaning while the ventricles are contracting, the atria are going to just have blood flowing in, blood flowing in, blood flowing in. And when atrial pressure exceeds ventricular pressure, that means then we're going to start squeezing. When the atrial pressure is higher than the ventricular pressure, because the ventricles are now relaxing and the atria are contracting, we're going to squeeze the blood through the AV valves, the bicuspid or mitral, and the tricuspid on the right. The cycle will start again. Hearts should beat around 75 times per minute. If someone's a really good athlete and really healthy, they probably will have a heart that's more efficient at beating, and it can beat fewer times to do the same thing, but around 75 on average. The cardiac cycle will last about an eighth of a second, and the systole, the atrial systole, the high pressure in the atria is going to be about 1/10 of 1 second. The ventricle will be about a third of a second. And it makes sense that it would be longer if you think about it, because there's more muscle involved and you're moving blood further. So squeezing more in the ventricle than the atria, yeah, we're moving blood further. Not a surprise. And then we have hey, my heart is at total rest, everything chilling out. That's about 4/10 of a second. We hope. That's where it should be. All right. So after ventricular repolarization, the electrical signal, you can relax now. Then the ventricles do relax. And the end systolic volume is the amount of blood you have remaining in the ventricles after you did the squeezing. We've said that. As you relax, the ventricular pressure drops. It causes backflow. It causes the blood to try to flow back. That makes the semilunar valves close to trap it. The ventricles are completely closed chambers. This is isovolumetric. I think I may have, yeah, dichroic notch. Okay, I accidentally pushed the wrong button and went back. So we've been through that twice. Sorry about that. Yeah, we've done that. So let's look right here. This, they go over this in the next few slides. This right here, the 2 of 2, this is probably the most important heart chart in the entire chapter. The reason why is because in the top band here, it's showing the electrical activity. In the middle one, it's showing the pressure changes that are happening. And all these timelines are synced up. In this middle part here, it's doing the volumes of the blood in the chambers. And down here, it's the physical activity of the chambers, what's squeezing, what's relaxing, and when it's doing those things. So amazing, amazing. We've already gone over all of this though, so I'm not going to do it again. But if you're having trouble understanding, email me or look at this chart, because I'll probably refer to this chart when I'm answering you. All right, so let's talk about the sounds we have in the heart. You know, that lumped up, lumped up. So that's the valves in the heart. Okay. The first sound, lumped up, the lub is the AV valves slamming shut as the ventricle gets ready to pump blood out. The second sound is the semilunar valves slamming shut as the ventricle's relaxing and the blood's trying to rush back. The pause between the two, that's heart relaxing. So if you listen very, very carefully, there's more than one sound in the lup and there's more than one sound in the dup. So in the lup, in the AV valves, the mitral or bicuspid is closing just before the tricuspid. Makes sense. We can remember that using alphabetical order. Bicuspid would become before tricuspid, mitral would come before tricuspid. In the semilunar valves, the aortic one is going to close slightly before the pulmonary one. Again, it makes sense. It can be alphabetized. A for aorta comes before P for pulmonary. These differences allow you to listen to each valve individually when you put the stethoscope in 4 different places. And here we have the 4 different places where to put them. And obviously, for aortic sounds, you want to be near the aorta. So pulmonary near the pulmonary trunk. Now that's going to be weird. You're going to say, but I thought the aorta was coming out of the left side and you're having me put the stethoscope on the right. Yes, but remember the heart is rotated slightly. The right side is forward and shifted to the left, and the left side is back and to the right. So yeah, it's the rotation that messes things up. It's the rotation that makes things seem odd. But trust the picture, know the picture. Um, so now we're going to talk about heart murmurs. The weird sounds you have in a heart that's not healthy. So if you have a valve that doesn't close well, you're going to hear swishing as the blood backflows into the heart. Like if it's a bad AV valve, the blood is going to go from the ventricle back into the atria some. If it's a stenotic valve, it's doing stenosis, okay? It fails to close all the way, it restricts blood flow through the valve, and then you get a high-pitched sound or a clicking as the blood is forced through this narrow valve. All right, we have some math here. You do need to know this math. It's not horrible math. Cardiac output, how much blood you pump out of the heart over time, is heart rate times stroke volume. That's all it is. So stroke volume is the amount pumped out by one ventricle with each beat. And heart rate is how many times that ventricle beats. So it's how much blood we're putting out from that ventricle in a minute. So we can change it. We regulate. We can do cardio inhibitory, cardio excitatory. Maximum output is 4 to 5 times in an unathletic person, 4 to 5 times what resting rate is. Maximal output could be 35 liters a minute in a trained athlete. Your cardiac reserve is the amount of difference you have between resting and maximal output. That's how much more the heart could move if it had to. So cardiac output will change if you change either the stroke volume or the heart rate. And you can regulate both of those things, which we're about to talk about. All right, so if you want to increase your cardiac output, you could increase the heart rate or increase the stroke volume or do both. How do you change the stroke volume? You could increase the amount of blood coming into the heart through the veins. You could preload the heart by having a larger volume when you're at rest. That's in diastolic volume being increased, which is on the flow chart. You could use chemicals that make the heart more contractile. We're talking about epinephrine, adrenaline, thyroxine, or having excess levels of calcium. All of those can make the heart more contractile. You could also have the end systolic volume go down. So anyway, and heart rate, obviously, you can raise or lower the heart rate. And if you do sympathetic, you're going to move more blood, fight or flight. Parasympathetic, feed or breathe, you're going to move less blood. And anyway, those affect your total cardiac output. So mathematically, the stroke volume is the end diastolic volume minus the end systolic volume. So an end diastolic affected by your ventricular diastole and the venous pressure. End systolic affected by arterial blood pressure and the force of contraction. There are 3 ways that we basically affect the stroke volume here: preload, contractility, and afterload. Preload is how much you stretch the heart muscles. If your pressure in the venous system is really high, you're pushing more blood into the heart. The heart's going to expand a little bit to take in all the volume. That's the preloading. And then it will contract a little harder to move it along. That affects your end diastolic volume. The relationship between preload and systolic volume is the Frank-Starling law of the heart. Yay, whatever. Cardiac muscle has a length-tension relationship. When we're at rest, the muscles are shorter than the optimal length, which leads to a dramatic increase in how well they can contract. Great. The most important factor in preload is venous return, how much blood is being returned to the heart. Slow heartbeat and exercise will increase venous return, make the heart work better. Increased venous return will distend or stretch the ventricles and increase the force you have of contraction. Contractile strength is how it depends on muscle length. We're looking at contractility as a method of changing output. If you increase the how well a muscle can contract, it will lower the end systolic volume. In other words, if you can make it better at contracting, it'll do a good job contracting, apparently. Things like epinephrine, adrenaline are going to increase the amount of calcium that rushes into the heart muscle, which will make more cross bridge formations. You'll get more contraction. Thyroxine, glucagon, epinephrine, digitalis, all of those are going to increase the amount you contract. Acidosis, too much potassium, calcium channel blocker chemicals, all of those are going to decrease how contractile the heart is, and thus decrease the output that it's capable of. Yeah, I'd say no figure 1821, but it's not saying anything we haven't said already. So, all right. So we did preload, we did contractility. Now we do afterload. Afterload is the back pressure from the arterial blood. This is a problem. If you have hypertension, if you have high blood pressure, that pressure is pushing on the semilunar valves, closing them. If you want to send blood from the heart into the aorta or the pulmonary trunk, you need to push harder just to open the valves to get the blood out of the heart. So aortic pressure would be around 80 millimeters of mercury. Pulmonary trunk would be around 10 millimeters of mercury. And like I just said, hypertension increases afterload. That's a fancy way of saying having high blood pressure means that you have to pump harder. So you have to have increased, you have to pump harder if you're going to move the blood. If you have trouble doing that, you're going to have more blood left in the heart, the end systolic volume. You're going to have a reduced stroke volume. You'll be pushing less blood out. Okay, stroke volume decreases as a result of decreased blood volume or a weakened heart. This is another problem. Cardiac output could be maintained by increasing the heart rate or how contractile it is. This is positive chronotropic factors. That's anything that speeds up the heart. Negative is anything that slows down the heart. So the rate can be regulated by the autonomic nervous system, by chemicals, other factors. When we say chemicals, we are including things like epinephrine. So, all right, the autonomic nervous system can regulate the heart rate. We already talked about that. The sympathetic nervous system that's your fight or flight. That's going to be activated by emotional or physical stress. Norepinephrine is released, it binds to receptors on the heart. That'll make the pacemakers fire more rapidly and increase the heart rate. The end diastolic volume is decreased. And what that means is you'll have a decreased fill, and that happens while you have a decreased amount of time to fill the heart. You could also have increased contractile abilities when the end systolic volume is decreased because of an increased volume that we eject. Okay, so we've got that. So if both end diastolic volume and end systolic volume go down, the stroke volume could stay the same without being changed. parasympathetic, the opposite of the sympathetic. If we think of the sympathetic as fight or flight, parasympathetic would be feed or breathe. This is when you're relaxed. Okay, this will impose sympathetic effects. Acetylcholine could hyperpolarize the pacemaker cells by opening sodium channels. That would slow the heart rate down. It wouldn't do anything to how well the heart contracts, but it would slow the rate down. Okay. So the nervous system, the heart has what they call a vagal tone when it's resting, muscle tone. So the parasympathetic is the major influence on the heart rate. You already know if you left the SA node alone to do what it wants, it would make the heart beat 100 times a minute. You already know your heartbeat is less than that. Thank the parasympathetic for slowing it down, for making your heart last longer. Okay. The autonomic nervous system regulating heart continued. We're now going to talk about what happens when fight or flight is activated, when sympathetic is activated. Well, that's going to inhibit the parasympathetic, and that means that we are going to probably get into one of those situations where we have to be finding food, we have to be finding mates. Anyway, so yeah, sympathetic, actually it's even more than that. It's not normal foraging, finding food. Sympathetic is, oh no, I got to run from the bear, there's danger, it's scary. When that happens, you're going to increase the venous return, increase the rate that the atria fills at. The atrial walls are stretched from the increased volume. That will stimulate the SA node, which increases the heart rate. It will also stimulate stretch receptors that activate sympathetic reflexes. One of the things that's not being mentioned here is what some of those sympathetic reflexes are. So the heart in the atria, if the atria are overstretched, they can release a hormone that it's called ANP, atrial natriuretic peptide. We'll talk about more when we do hormones, but this chemical tries to get you to urinate more. And the reason why is to pee out the fluid in your body, to decrease the fluid volume so you can lower the blood pressure a little. So, okay, so chemical regulation of the heart, continuing hormones. So talking about thyroxine increasing the rate, epinephrine increasing the rate, that's great. And ions, how much potassium, how much calcium you have. Those, you have to maintain things for normal heart function, you have to keep them at a constant level. If you change them and get imbalances, you can throw off the heart rate, make it really difficult to work properly. Hypo means below, hyper means above. So hypocalcemia, that means you don't have enough calcium around. That will slow the heart, depress the heart. Hypercalcemia, you have too much calcium. It will increase the heart rate and make the heart super contractile. Potassium is what we're talking about with the kalemia. You should know that from the Her Happy Marriage. Why am I? Wow. Okay, hold on a second. Potassium. Yeah, so we're talking potassium. Hyperkalemia is too much potassium. Hypopotassium is too little potassium. Give me a second here. Okay, so while we were talking about having too much or too little sodium or potassium or calcium and the effects it can have, I wanted to point out that there have been several cases in the US. This one was Give me a date. Thank you. This was in 2005 of fraternity hazing where they were having the person drink water and do exercises, and he drank so much water that he diluted the chemicals in his body and it killed him. So understand that what the book was saying in their PowerPoint. Let's go back to that. Actually, hold on. Close that. I need to reopen before we can. There we are. Now I can share that screen. That screen didn't exist to share a moment ago. All right, now we have the full view. So we talk about feeble heartbeat arrhythmia. If your potassium levels go low, that is, or a depressed heart rate from low calcium. Same thing. If you dilute your sodium too much, you can stop the heart completely and kill the person. Let's move on to more pleasant topics here. Other factors can affect heart rate. Age. This, by the way, is partially related to size. Talking about how the fetus has the fastest heart rate and how it gets lower with age. Yeah, but if you think about it, small animals like a hamster have a much faster heart rate than a dog or a cat, which has a much faster rate than an elephant. So I'm not sure if it's actually the age or the size, but anyway, women tend to have a faster heart rate than men do. If you're exercising, your heart rate goes up, but trained athletes who do it all the time, they're going to have a slower heart rate because their heart becomes more efficient. If your body temperature goes up, your heart rate is going to go up. The reason why is you're going to be trying to cool off by opening up all the capillary beds, and your heart will be pumping harder to push the blood through all those capillary beds close to the skin so that it's easier to cool off. Tachycardia is what we have if we have an abnormally fast heart rate. If it happens all the time, it could eventually cause fibrillation. Bradycardia is what happens if we have a heart rate that is too slow. In non-athletes, this could cause a problem getting enough blood circulation. If you have, again, if your heart rate, if you are a good enough athlete, if you have a healthy enough heart and efficient enough heart, your heart can do the same amount of work beating slower. So bradycardia is just saying the heart is slow. It's not talking about the cardiac output. If you can maintain cardiac output while having a lower heart rate, that's okay. But you have to circulate the right amount of blood to do it. All right, so congestive heart failure is when your cardiac output gets so low that you can't circulate enough blood to give your tissues the oxygen they need. This will happen when the heart is weakened. It could be from hardening of the arteries in the heart, hardening of coronary arteries. When this happens, the heart is low in oxygen itself, and it's bad at contracting. Persistent high blood pressure can cause congestive heart failure. If your aortic pressure is over 90 millimeters of mercury, your myocardium is going to have to work harder with every stroke, to push the blood out past the semilunar valves. If you have a chronic increase in stroke volume, the heart's going to try to get rid of that extra blood, and that means that the heart will probably get larger and weaker as it tries to do this. If you have multiple heart attacks, the heart gets weaker every time as you replace the living tissue with scar tissue. We've said that before. You know that there's research right now into trying to use stem cells to fix that. Dilated cardiomyopathy, the ventricles can get stretched out and flabby, and the myocardium, the muscle layer, is getting weak. This could happen from chronic inflammation or drug toxicity. Um, so anyway, moving on. Congestive heart failure could be on either side of the heart. On the left side, if it happens, you have pulmonary congestion where blood's backed up in the lungs because you're having trouble getting it to the left side of the heart. On the right side, peripheral congestion, the blood will pool in your organs, it'll cause edema. Failure on either side will ultimately weaken the other side. This will cause a seriously weakened heart. The treatment is remove fluids, take drugs to increase contractility or reduce afterload, drugs to cause you to urinate more. Okay, and now we're through all the scary stuff, and that's really scary stuff. The human heart is made out of the embryonic layer that we call mesoderm, and it says begins as 2 endothelial chambers. I know that sounds weird, like, oh, we have a 4-chambered heart. Well, you start out with a 2-chambered heart, just like fish have. Fish have a 2-chambered heart. Anyway, so we start as 2 chambers of endothelium that fuse to form a single active pumping chamber. That's the 22nd day of pregnancy. The tube's going to get 4 bulges that are going to be the earliest chambers. Sinus venosus will become the right atrium. Let's go to the picture so you can see sinus venosus. Anyway, so here we have tubular heart, 2 chambers on day 22. By day 24, we're starting to form these bulges. Bulge there, bulge there, bulge there. That's the future ventricle. Then we're going to get an S curve going on. Anyway, so sinus venosus will form the right atrium, coronary sinus, and the SA node. The atrium becomes the pectinent muscles of the atria. Remember, those are the tiny ones that are the wrinkles you see in the wall of the atria, which are similar to the crossbars of flesh, the trabecula carne that you see in the ventricle. Anyway, the ventricle of this primitive 2-chamber heart, that's going to become your left ventricle. Your bulbus cordis on that primitive heart, that'll become the aorta, the pulmonary trunk, the right ventricle. This tube will contort, bend around. There'll be structural changes that'll modify it into a 4-chambered heart. That'll happen by day 35. The 2 structures there will let you bypass the lungs. The foramen ovale, that's the hole in the interatrial septa. That allows some of the blood to go from the right atria into the left atria and then go through the body. You might say to yourself, why? What good is that? Well, before I answer, let's look at what the next one is. The ductus arteriosus connects the pulmonary trunk to the aorta. Again, we are bypassing the pulmonary circuit. Both of those take blood that would, because it's right side of the heart, go to the lungs. Like, no, just send it out to the body. Why? Well, because when you're a baby in the womb, your lungs aren't doing anything to give you oxygen. The oxygen comes in through your umbilical cord. So send blood to the lungs, enough to help them grow and keep them alive, but don't send all the blood in the body there because they're not doing anything. Send the blood out and to the body. So the foramen ovale lets you skip the right ventricle and the pulmonary trunk. If things get to the pulmonary trunk, then you can send them through the ductus arteriosus, so you can still skip the lungs. Both of these should close at birth. And what's left of the foramen ovale will be what we call the fossa ovalis. It's that oval-shaped scar that is on the septa between the atria. You can see it in the right atria. The ligamentum arteriosum, that duct between the two, just shrinks down till it looks like a thread. You're left with no space at all, just the connective tissue around it. Congenital heart defects, there are 40,000 per year. If someone's born with a heart defect, we can try and fix it with surgery. Most of them are two types. The mixing of oxygen poor and oxygen-rich blood, that would be things like we said, the foramen ovale not closing, the ductus arteriosus not closing. The other problem could be if you have narrowed valves or vessels that make the heart have to work harder. And the other one is the tetralogy of Fallot. Hold on a second. I'm going to look that one up. Okay, I was mispronouncing that. It's a French name, so tetralogy of Fallot. But anyway, the CDC, Centers for Disease Control, says that there are 4 different types of defects that they lump together with this name. You could have a hole between the ventricles and the interventricular septum doesn't form well. You could have narrowing of the pulmonary semilunar valve, making it hard to put blood into the pulmonary semilunar valve. You could have an enlarged, oversized aortic valve, so big that it actually could be taking blood from both ventricles, and it's causing mixing of oxygenated, deoxygenated blood. Obviously not good. Or the right ventricle could be thicker than normal. So ventricular hypertrophy. Anyway, those are the things that the book says are the tetralogy of Fallot. Okay. There we go. So both of those problems could be a tetralogy of Fallot. That I was reading the slide wrong. It was embedded in there already. But it was still good to look up because now I know how to pronounce the name. But if you have both of those things, that's the same problem. So here are 3 examples of congenital heart defects. You could have a hole between the ventricles. You could have a narrowed aorta, so it's hard to push blood through. You could have the tetralogy of Fallot, where you have both of those types of problems. And yeah, nasty. Okay, so these pictures should have been on the last slide. Now let's talk about age-related effects. Over time, basically stay active, exercise your whole life to keep your heart healthy. Over time, you have age-related changes to the heart that are all bad. Sclerosis, hardening of the arteries, thickening of the valve flaps, those cause heart murmur. Declining cardiac reserve, the heart gets less efficient, so you just can't get like rest will stay at rest. But remember, the reserve was how much more the heart could output if it needed to. You're not going to have as much of that. You won't be able to run from the bear as well if you have to run from the bear, or whatever reason you're having to do that. Fibrosis of the cardiac muscle, the heart could get stiffer and less muscular and more fibrous, and that means that you could have fibers messing with those conducting cells. I'm talking about things in the AV bundle, the bundle branches, the Purkinje fibers. Atherosclerosis can be solved by having a better diet. And that is the end of this PowerPoint. So let's shut it down.